Hello and welcome. I'm Fernando, a GP in the UK. Today we're looking at the NICE guideline on gout, or NG219, focusing on what is relevant in primary care only. Right, without further ado, let's jump into it. Looking at the clinical presentation, we will suspect gout if either the patient has tophi, or there is rapid onset, often overnight, of severe pain together with redness and swelling in one or both first metatarsophalangeal joints, although we will bear in mind that gout can affect other joints. Other differential diagnoses that we have to consider in people presenting with a painful red swollen joint are septic arthritis, and let's remember that septic arthritis is a medical emergency. And in most cases, the patient should be sent to the emergency department. This is because of the risk of rapid joint destruction, systemic spread, and because the delay in treatment worsens outcomes. We should also consider other inflammatory arthritis, as well as calcium pyrophosphate crystal deposition. And let's stop here for a moment. What is calcium pyrophosphate crystal deposition? It is often referred to as pseudo-gout because it can cause acute joint inflammation, mimicking the symptoms of gout. However, it is caused by calcium pyrophosphate crystals rather than uric acid crystals. Diagnosis is confirmed by synovial fluid analysis, although it can be suspected if chondrocalcinosis is seen on X-ray. Now, going back to gout, if instead of presenting with a painful red swollen joint, they present with chronic inflammatory joint pain, we should also consider chronic gouty arthritis. In terms of making a diagnosis of gout, as always, we will start with a detailed history and examination. We will then check urate and confirm the clinical diagnosis if the serum urate level is 360 micromole per liter or 6 milligrams per deciliter or more. If the serum urate level is below this threshold during a flare and gout is strongly suspected, we will repeat it at least 2 weeks after the flare has settled. This is because during a gout flare, the serum urate can be temporarily low due to the inflammatory response and redistribution of urate into the tissues. This means that a single low urate measurement during a flare does not rule out gout. If the diagnosis remains uncertain or unconfirmed, other tests may be considered, such as joint aspiration and microscopy of synovial fluid or CT imaging of the affected joints, although normally this would be in secondary care. As treatment of gout flares, we will offer a non-steroidal anti-inflammatory drug, colchicine, or a short course of an oral corticosteroid for first-line treatment, taking into account the patient's individual circumstances. When giving a non-steroidal anti-inflammatory drug or oral steroid, we will consider adding a proton pump inhibitor for gastric protection. We will also explain that applying ice packs to the affected joint may also help. If non-steroidal anti-inflammatory drugs and colchicine are contraindicated, not tolerated, or ineffective, we can consider an intra-articular or intramuscular corticosteroid injection. However, at the moment, the use of steroids for gout, both orally and parenterally, is an off-label use. We should not offer an interleukin-1 inhibitor in primary care, but we will refer to a rheumatology service instead. And what is an interleukin-1 inhibitor? It is a type of biologic drug that blocks the activity of interleukin-1, a key pro-inflammatory cytokine involved in the body's immune response in conditions such as gout and rheumatoid arthritis. They are particularly useful in cases where non-steroidal anti-inflammatory drugs, steroids or colchicine are not effective or cannot be used due to side effects and contraindications. After a gout flare, we will arrange follow-up to check the urate level, provide information and assess comorbidities, review medications, discuss long-term urate lowering therapy, and discuss lifestyle. In this respect, we will explain that there is not enough evidence to show that any specific diet prevents flares or lowers serum urate, and we will just advise a healthy, balanced diet. However, we will explain that excess body weight or excessive alcohol may exacerbate gout flares and symptoms. We will also explain that the disease progresses without intervention, and that gout is a lifelong condition that benefits from long-term urate lowering therapy to prevent flares, shrink tophi, and prevent long-term joint damage. Now that we have had a look at the management of an acute flare, let's look at the long-term management, which involves urate lowering therapies. Anyone with a diagnosis of gout is likely to benefit, but it is particularly important for those who have multiple or troublesome flares, take diuretic therapy, have developed tophi or chronic gouty arthritis, and finally anyone with CKD stages 3 to 5, that is anyone with an eGFR less than 60. However, as explained, we should discuss therapy with everyone with a gout diagnosis, as they're likely to benefit from treatment long term. Normally, we will start urate lowering therapy at least 2 to 4 weeks after a gout flare has settled. However, if flares are more frequent, it can be started during a flare. In order to prevent gout flares when starting or titrating urate lowering therapy, we can offer colchicine while the target serum urate level is being reached. If colchicine is contraindicated, not tolerated or ineffective, we can use a low-dose non-steroidal anti-inflammatory drug or a low-dose oral corticosteroid. And for both, a proton pump inhibitor can be given for gastric protection. How do we prescribe urate lowering therapy? Well, we will follow a treat-to-target strategy, where we start with a low dose and use monthly serum urate levels to guide dose increases as tolerated until the target urate level is reached. We will aim for a target urate below 360 micromoles per liter or 6 milligrams per deciliter, but we will go for a lower target of below 300 micromoles per liter or 5 milligrams per deciliter if they have tophi or chronic gouty arthritis or continue to have flares despite having a level below 360 micromoles per liter or 6 milligrams per deciliter. We will explain that urate lowering therapy is usually continued after the target serum urate level is reached and is typically a lifelong treatment. What are the recommended drugs? We can offer either allopurinol or febuxostat as first-line treatment. If the target urate level is not reached with the first drug, or if it is not tolerated, we will consider switching to the second drug. For patients with major cardiovascular disease, we will go for allopurinol first line. This is because studies suggest that allopurinol may reduce cardiovascular events in those with pre-existing cardiovascular disease, whereas conversely, febuxostat has been associated with an increased cardiovascular risk. Once the target has been reached, we will monitor urate levels annually. Finally, we will consider referring to rheumatology if the diagnosis is uncertain, treatment is contraindicated, not tolerated or ineffective, they have CKD stages 3b to 5, that is if they have an eGFR below 45, or they have had an organ transplant. And that is it, a review of the diagnosis and management of gout in primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for watching and goodbye.